Please welcome ARVO President, Dr. Bill Mieler.
Thank you very much, and once again, welcome to ARVO's closing keynote session. Now it's truly my honor to open the keynote closing session on Ebola and the eye, a story of discovery and uncertainty. This topic fits very readily into our 2015 ARVO theme of powerful connections, vision research, and online networking. Though, of course, Ebola virus story involves not only vision, but also systemic viral infection with a high risk of death. In late summer of 2014, the world was faced with a rapidly exploding crisis in West Africa. As we all know, the dissemination of information around the globe is almost spontaneous, and the concerns for a worldwide outbreak of infection and death consumed the news headlines for a number of months. At a time when most people wanted to distance themselves from the risk of infection, a brave individual and team of individuals, whom we will meet shortly, volunteered to go to the front lines. Today we hear about the challenges in the management of the Ebola outbreak, scientific advances in its containment and treatment, and new previously unreported ocular findings. You'll hear very shortly from Dr. Ian Crozier, who contracted the disease, survived, and has a truly amazing story to tell from both sides of the curtain. I'd like to thank Justine Smith and Stephen Ye for helping to put this session together, and now I'll introduce Stephen Ye, who will lead the program. Stephen.
Well, thank you, Bill, and the attendees, as well as the ARVO Program Planning Committee, as well as certainly the ARVO Executive Committee for allowing us to share with you this incredible story of Ebola in the eye. I'd first like to introduce our panelists. This is Dr. Jay Varkey. He's an assistant professor of internal medicine in the Division of Infectious Disease at Emory University Hospital, and also was one of the 5 physicians who cared for Dr. Crozier, as well as the other Ebola survivors in the Serious Communicable Diseases Unit. Next, we have Dr. Tim Uyeki, who's from the Centers for Disease Control and Prevention, and he's been one of the leaders, or actually the leader, of the clinical team in terms of the Ebola response from the CDC. I'm Dr. Stephen Ye, and I work in uveitis and vitreoretinal disease at Emory University Hospital. And next, we have Dr. Jessica Shanta, who's our graduating senior resident, who will be going into medical retina and uveitis. And then last but certainly not least, we have Dr. Ian Crozier. He is a Vanderbilt-trained infectious disease specialist who's actually been in Uganda for the past 6 years with a specialization in HIV, AIDS-related diseases, and has been training Ugandan doctors with regards to these types of conditions. We certainly appreciate his presence, and he has been called potentially the sickest Ebola survivor ever, and we certainly appreciate everybody's interest in this session. So first, I'd like to introduce Dr. Tim Uyeki to come to the podium.
Thanks, Steve, and I'd like to thank ARVO for sponsoring this, and we really appreciate the time of the participants here. I have no conflicts to disclose. What I'm going to talk about a little bit is some background about Ebola virus, talk a little bit about the epidemiology, particularly of the current outbreak, and touch on some of the relevant clinical issues. So Ebola virus first came to the world's attention in 1976. There were actual outbreaks in the Democratic Republic of Congo, at that time called Zaire, as well as in Sudan. This virus is a single-stranded negative sense RNA virus. It is a filamentous virus, is in the family filoviruses, Filoviridae. The other kind of filoviruses are Marburg viruses. There are 5 species of Ebola viruses, Zaire, Sudan, Bundibugyo, Typhorus, and Reston, and 4 of the 5 have infected humans. Reston has not. An infection with this virus typically causes Ebola virus disease, and I'll talk about some of the clinical manifestations, and we do observe very high mortality. The natural reservoir is not completely known, but it's believed to be fruit bats. There's some genetic evidence of that, but it's not definitive. And to date, since the 2 outbreaks in 1976, there have been more than 20 outbreaks that have occurred in East, Central, and West Africa, primarily in East and Central Africa, though. And by far and away, the current outbreak, which started really at the end of 2013, but really took off in the spring of last year, this is by far the largest compared to all of the cases from all of the outbreaks to date before this. So how do humans get Ebola virus infection? Well, we believe that it's through direct contact of mucous membranes or breaks in the skin. It could be microscopic breaks in the skin. And that contact could be with an infected animal. It could be with the blood or bodily fluids. It could be vomit, feces, blood, other bodily fluids of a symptomatic person. A person who's infected with Ebola virus is actually not very contagious until symptoms develop. And early on in the clinical course, they're not that contagious. They become much more infectious as viremia develops and the severity of disease increases. Another way to get Ebola virus infection is unfortunately through contact with corpses of individuals who died of Ebola virus, particularly at these traditional burial ceremonies, which takes place in many places of sub-Saharan Africa. The person dies, a woman washes the body, and then people come from surrounding villages and they touch the body. And the virus is very concentrated in the epidermis, and so there is potential for corpse to human transmission, and that's unfortunately driven a number of outbreaks. The question is whether there's sexual transmission possible from an Ebola survivor during the convalescent phase, and there's some evidence that a virus can persist in the semen, but there's not been a proven case of sexual transmission after clinical recovery for Ebola virus disease. Recently, in the last week, there's a publication in the MMWR suggesting that this may have happened in Liberia. There is one case of Marburg virus sexual transmission, so it is possible for Ebola. And then we also know that nosocomial transmission, in addition to contact with blood or bodily fluids, can occur through contaminated syringes and needles, and this was the driver in the original outbreak in Kikwit in 1976. So the ecology of Ebola virus, again, we think the natural reservoir is in bats, and there can be transmission to forest antelopes, these so-called diker antelopes, or some non-human primates, and they may die, and that's the end of the story in terms of public health. But if there are people in rural areas that come across these animals that have died, they have contact with them, then there can be transmission. Now, this is a figure that shows where previous outbreaks have happened, typically in Central and East Africa, but recently in West Africa. So how do we prevent and control these outbreaks once they start? Well, the key is the traditional public health interventions of isolating suspected and confirmed patients. You want to get them into an Ebola treatment unit. We clearly want to implement recommended prevention and control measures to prevent further spread. And as I mentioned, the traditional burial ceremonies is one event in which there can be a lot of transmission from corpse to participants in the burial ceremonies. So we want to stop those traditional burial ceremonies. We want to promote safe burials. And clearly active surveillance for new cases is critical, and particularly tracing contacts of particularly close contacts, household members, other close contacts of confirmed cases. We do try to establish field laboratories, and that's been going on for a number of years. And in this particular outbreak, establishment of laboratories to perform Rt-Pcr to confirm Ebola virus infection or to rule it out is critical. And education, social mobilization of the community is really, really important. You need to generate understanding of how the virus is transmission. There's a lot of fear, a lot of stigmatization. You need the cooperation of the community. Of course, there are many, many challenges, and I'll just mention a few here. As I'm going to talk about some of the clinical manifestations, these are really non-specific. There isn't this hallmark of something that's pathognomonic for Ebola virus disease. We have no treatments, no proven treatments, and this causes a very severe disease with high mortality. In many of the places that have been affected by outbreaks in the past, as well as this current outbreak, there's a lack of infection control. And so trying to ramp up quickly infection control that's really recommended to bring in the personal protective equipment. These are big challenges, and you really want to stop nosocomial transmission or prevent it as much as possible. And there's a lack of healthcare infrastructure, particularly the affected countries for this outbreak really did not have good healthcare or public health infrastructure in place prior to this outbreak, and it's been devastated by these outbreaks. Similarly for laboratory testing, no capacity or low capacity to actually do the appropriate testing for Ebola virus. The lack of the appropriate public health response, and sometimes the lack of community cooperation, mainly because of fear and misunderstanding. So if we go back to the beginning of this current outbreak, it's thought that patient 0 perhaps was the index case, it's believed, was a very young child in southeastern Guinea. You can see where the arrow is. This child is supposed to have been right under a tree in which there are many, many fruit bats roosting, and perhaps that was bat to human transmission. Nevertheless, the child became ill. There was subsequent transmission to family members as well as caregivers. There was transmission at burial ceremonies. And then as some of the ill moved around in Guinea, in fact, going from southeast Guinea to southwestern Guinea or northwestern Guinea, there was spread further. Cholera was first suspected. Ebola was not suspected. Once in hospitals, there was nosocomial transmission. The WHO African Regional Office suspected Lassa fever, which is more common in these areas. There hadn't been these kinds of outbreaks of Ebola virus disease in these countries in the past. And it wasn't until late March that specimens were sent to the Institut Pasteur, France, to confirm Ebola virus infection. So this is sort of the chronology. We had spread further in Guinea, and then spread in the spring to Liberia and Sierra Leone, and it wasn't until early August that WHO declared public health emergency of international concern. Now, if we look at what's happened recently, you can see this is confirmed cases of Ebola virus disease by week in Liberia, Sierra Leone, and Guinea, and the peak was really in the summer and the fall of last year, and since the beginning of this year, cases have declined. And luckily, in the past week, there have only been 9 confirmed cases in Guinea and Sierra Leone, and we're hoping that in 2 days, Liberia can be declared Ebola-free. That would be 42 days after the last case was buried. And this is a figure that shows the impact in Sierra Leone, Guinea, and Liberia. The darker blue colors are the concentration of cases, and the red and yellow show the hot spots. And the hot spots really are in Guinea, in the southwest and northwest of Guinea, and the northwest of Sierra Leone. Clinical issues, the incubation period for Ebola virus disease is approximately 9 to 11 days. The range we typically say is 2 to 21 days. It may be much less in young children, and it may be less with percutaneous infection. The initial signs and symptoms are very nonspecific. Typically it's fatigue, a lot of weakness, loss of appetite, insomnia, myalgias. Not everybody mounts a fever or is feverish, but many do, and there's malaise. And starting around day 4 or 5, you start to see the development of gastrointestinal tract symptoms, nausea, vomiting, diarrhea, abdominal pain. You can see rash, hiccups, you can see conjunctival injection. The hallmark that we're seeing in this epidemic with severe disease is profuse diarrhea. And then complications, more severe disease, you'll see hypovolemic shock, renal failure, DIC, septic shock. Some patients have gone into respiratory failure. There are neurological manifestations, delirium, encephalopathy, or encephalitis. Some patients manifest a vascular leak. You can see peripheral edema. Frank hemorrhage is not that common, and that's why this was changed from viral hemorrhagic fever really to Ebola virus disease. There is frank hemorrhage, particularly in critically ill patients, but it's actually not that great a proportion of patients that have bleeding. Bacterial co-infection is possible, and that contributes to disease severity. The pathogenesis is that this virus can infect many tissues, and it triggers a cytokine response, and it's probably both the direct infection as well as the inflammatory response that really is contributing to disease damage and sepsis. Diagnosis is based upon detection of viral RNA in blood specimens by Rt-Pcr. And the hallmark of clinical management really is supportive care in establishing proper infection control right away. There's no definitive treatment that's been established, so really it's very, very close critical care management, fluid and electrolyte replacement, and for those that go into organ failure, advanced organ support for respiratory and renal failure. And that's really not that possible in West Africa, but it has been used in Europe and in the US. There have been more than 26,000 cases reported to WHO, with more than 11,000 deaths, and in particular, there have been 868 cases reported in healthcare workers with 58% case fatality proportion. And I believe that the numbers of reported cases are an underestimate of both cases and deaths. The most impacted countries are Sierra Leone by far, and Liberia, as well as Guinea. But there have been cases identified in Mali, Nigeria, and Senegal. And then outside of West Africa, there have been cases that were imported or secondary cases in the US, the UK, and Spain. And overall mortality tends to run 40 to 70% in most Ebola treatment units in West Africa, so very high case fatality proportion. In the US and Europe, there have been 26 Ebola virus disease patients that have been managed. These have been either medevaced after diagnosis in West Africa, or there have been some secondary or imported cases diagnosed. In the US, we've had 11 Ebola virus disease cases managed in 5 hospitals in the US, including Emory University Hospital, and you'll hear about that next. 7 of these have been medevaced, 2 were imported and diagnosed in the US, and 2 were secondary cases in healthcare workers in 1 hospital. Overall, 2 of the 11 have died for a case fatality proportion of 18.2%. I just want to close by giving a brief update on vaccines and therapeutics. We have no approved vaccine for Ebola virus disease. There are phase 1 studies of candidate Ebola vaccines that have been conducted in the US, in Europe, and in Africa. These do suggest safety and immunogenicity, although we do not know the duration of protection. And there are clinical trials that have started in Liberia, in Sierra Leone, and in Guinea. The NIH is doing a randomized controlled trial in Liberia and trying to extend it to other countries, and the CDC is also doing a study of a different vaccine in Sierra Leone. We have no approved treatment for Ebola virus disease. There are a number of therapeutics in development. Many of the patients in the US and Europe have received 1 or more investigational agents on the basis of compassionate use. These are uncontrolled, and many of these were multiple overlapping therapies. I don't think we can draw any inferences on the clinical benefit. We have some suggestion about the harms, but we don't know about the benefit. And what we need is randomized controlled trials. And so the kind of therapeutics in development are antivirals as well as immunotherapeutics, or different classes of drugs. And there are different study designs that have been implemented, both single arm as well as, I want to just highlight one randomized controlled trial, which is conducted by the NIH. It's been implemented in the US, in Liberia, and in Sierra Leone. So the very good thing about the outbreak is that it has really dwindled. There's hope. The hope is in sight that this will be controlled. That's great for public health and the people of West Africa. It's not very good for clinical trials. So it's unlikely that we're going to meet enrollment in any of these clinical trials, but that's actually okay because we do not want this outbreak to keep going. We want it to stop. So thanks very much.
Thank you, Tim. It's an honor for me to be here with my colleagues to describe Dr. Ian Crozier's hospital course at Emory. When persons with Ebola like Dr. Crozier were repatriated to the United States, I was often asked, why Emory? The short answer is because we were asked to and because we gladly accepted. The longer answer is because Emory has a biocontainment unit specifically designed to care for patients with serious communicable diseases, and more importantly, a dedicated team of healthcare workers who have been trained in the key infection control principles necessary to care for patients with Ebola safely. This is a schematic of the Serious Communicable Disease Unit, or SCDU, at Emory University Hospital. Although biocontainment units are not necessarily needed to treat a patient with Ebola virus disease, specific features in the design of this facility in many ways made the SCDU the ideal place to care for a patient with Ebola, while at the same time minimizing the risk for transmission to healthcare workers, other patients, and the general public. The two individual patient rooms seen here and here are designed to deliver the level of care equivalent to that of a standard intensive care unit, allowing healthcare workers to provide aggressive supportive care, including mechanical ventilation and, if necessary, dialysis. Patient care rooms are also constructed with seamless surfaces on the floors and walls to facilitate effective surface disinfection. To maintain staff safety, the units included dedicated space for staff changing areas located here, as well as storage areas for PPE here and here, as well as a separate point of care lab for testing specimens that may contain large amounts of Ebola virus. However, I would argue that the key for caring for patients with Ebola is not just the physical environment, but having a trained and competent team. The heart and soul of the SCDU team was, and continues to be, 21 ICU nurses that, for critically ill patients with Ebola, were present at the bedside 24 hours a day, 7 days a week, often for 3 or 3.5 hours at a time. We also had 10 laboratory technologists to staff our point of care laboratory, as well as 5 senior staff members from the environmental services to help handle the incredible amount of medical waste that we generated. I had the honor of being one of 5 ID physicians that cared for 4 of the patients we treated for Ebola at Emory. Here I'm pictured with 3 of my other infectious diseases colleagues, as well as our first patient. Our 5th member was our medical director, Bruce Ribner, who's also a hospital epidemiologist and who constantly emphasized that meticulous attention to infection control was again the key aspect of safely caring for patients with Ebola. So regarding infection control in the SCDU, and this is a point that I can't overemphasize, PPE alone is not enough. To safely care for patients with Ebola, healthcare workers must be trained to safely don, and more importantly, doff PPE, and they must be competent. We had motivated nurses as well as physicians who wanted to be part of the SCDU team, but could not demonstrate competency in doffing their PPE, and therefore they were asked not to be part of the direct care team. So training and competence are critical because patients with Ebola virus disease, especially those who are critically ill, have massively high viral loads, in some cases as high as 10 to the 8th viral particles per ml of blood. Furthermore, Ebola virus is highly infectious. Some models suggest that mucous membrane exposure to as little as 1 nanoliter of blood in a patient with a high viral load may be enough to transmit infection. Therefore, frequent cleaning and disinfection are absolutely critical in order to maintain a safe environment. Environmental services did not enter any of our patient care areas. All cleaning was performed by the nurses and physicians who cared for their patients. Surfaces, as you can imagine, were constantly being wiped down by disinfectants. We had one of our mottos in our unit was that if you have time to lean, you have time to clean. How well did we do? When our patients were discharged, we took multiple environmental samples, including those of our patients' phones, their computers, bed rails, call button, toilet seats, other bathroom surfaces. All samples that we tested negative for Ebola virus by Rt-Pcr. So in July of 2014, Emory cared for the first 2 patients to be treated for Ebola virus disease in the United States. Both patients were successfully discharged home to their families in the 3rd week of August. Approximately 2 weeks after we discharged our second patient, Emory was notified that we'd be receiving a third patient, a 43-year-old physician who had contracted Ebola while working for the WHO in Sierra Leone. We would later find out that this physician was Dr. Ian Crozier. Ian arrived to Emory by air ambulance on September 9th, 2014, day 4 of his illness. Although initially afebrile, shortly after arriving to Emory, Ian spiked a fever to 40 degrees Celsius. He was ill-appearing and rapidly developed delirium. Now, although myself and my colleagues would get to know Ian and his family very well over the next several weeks, I think it's important to realize that in order to maintain his privacy, for much of the rest of the world, Ian and his hospital course remained, as CNN put it, unknown. Unfortunately, Ian's hospital course was complicated. By day 6 of his illness, he had developed a very characteristic but severe gastroenteritis that Dr. Yoko just mentioned that really resembles cholera, with up to 5 to 10 liters of stool output per day. At the same time, he developed a paralytic ileus, marked by nausea and vomiting, which made enteral feeding impossible and required parenteral nutrition. Despite aggressive hydration to keep up with his massive GI losses, by day 9, Ian's urine output had decreased, his creatinine was beginning to rise, and a spun urine revealed muddy brown casts consistent with acute tubular necrosis. At the same time, he was developing increasing respiratory distress, consistent with non-cardiogenic pulmonary edema. After not responding to large doses of diuretics, I, with the assistance of one of my anesthesia colleagues, made the decision to intubate Ian and to place him on mechanical ventilation. By day 11, Ian had developed a supraventricular tachycardia that required an amiodarone drip. He also developed a worsening mixed metabolic and respiratory acidosis. As a result, he was started on dialysis. Now, I want to pause here to comment that these were difficult days in the SCDU. Ian's prognosis was filled with uncertainty. We know that most patients with Ebola virus disease who die of their disease die between days 8 and 10. Clinically, Ian had reached his nadir. At a molecular level, he had also reached his nadir. The cycle threshold for Ebola virus in his blood bottomed out at 20, indicating a viral load that was at least 100 times higher than either of the 2 patients we had previously cared for. But there were some hopeful signs. Thanks to Dr. Yoko and our CDC colleagues, we're beginning to see evidence of IgM antibodies to Ebola virus in Ian's blood. Our goal then was to continue aggressive supportive care until he developed the antibodies that were needed to reduce his viremia and hopefully facilitate clinical improvement. On illness day 21, nearly 2 weeks after being intubated, Ian was able to be extubated. He did, however, remain delirious. However, over the following week, his mental status improved, and on illness day 29, for the first time in nearly 3 weeks, he was able to ambulate with assistance. By day 35, dialysis was held, and for the first time, his blood tested negative for Ebola virus by Rt-Pcr. And then finally, after 40 days at Emory University Hospital on a glorious autumn Sunday morning in Atlanta, Ian was able to be discharged home to his family. However, he had lost 30 pounds, fatigued easily, had significant proximal muscle weakness, which caused an unsteady gait, and had word-finding difficulties. He would require follow-up care. Now, in addition to the aggressive supportive care that I described, Ian received an experimental small interfering RNA agent called TKM-100802, as well as convalescent plasma donated by a fellow EVD survivor. In this uncontrolled setting, it's impossible to scientifically determine whether these therapies improved his course, worsened his course, or did nothing. Nearly a month after being discharged from Emory University Hospital, I saw Ian in my ID clinic. He was now ambulating up to 2 miles daily. The occasional word-finding difficulty that was noticed at discharge had nearly resolved or was markedly improved, and he was gaining weight. Unfortunately, he had developed new symptoms. This included hair loss, with his hair coming out in clumps. He had markedly decreased hearing, especially on the left side. He had low back pain, worse than chronic, right-sided, almost resembling a sacroiliitis. He also had severe enthesitis, most noticeably at the bilateral Achilles tendons. And then, sort of most strikingly, he had developed, and this initial symptoms were noticed shortly after being discharged from the hospital, occasional blurry vision bilaterally. And these would be transient, burning, lasting for a few seconds to minutes at a time. But both of us aware that eye problems as well as uveitis were being increasingly recognized among EVD survivors. It was at that time that I referred Ian Crozier to my friend and colleague, Dr. Steve Yeh in the Emory Eye Center, who I will turn over to next.
Well, it really has been a privilege to work with this team, and it's an additional privilege and humbling to be able to talk to you about the ophthalmic management of Ebola virus disease-associated pan-uveitis, or at least initiate the story for the very first time. I'd like to acknowledge our collaborators, both at the CDC, Emory University Hospital, and also some of our collaborators in West Africa, and certainly the authors on the paper that is to be published, I think, currently. These are my financial disclosures. So as Dr. Yeki nicely outlined, this is the largest Ebola outbreak in history, and I won't repeat any of the details, but suffice it to say, for many of us, really the awareness of what was going on really came to light in early August when US healthcare workers were evacuated to the Atlanta area. We had Dr. Kent Brantley, followed by Ms. Nancy Wrightbull, and also a mysterious anonymous patient 3, who is unknown to us, but will become very familiar with us over time. A quick review of the PubMed literature only revealed one citation. In the Democratic Republic of the Congo in the 1990s, there was a report of 3 patients of 20 Ebola survivors who developed uveitis with 1 survivor outside of this cohort. They developed uveitis 42 to 72 days after the onset of Ebola hemorrhagic fever, and the presenting visual acuities ranged from 2080 to 2200. Both anterior and posterior uveitis syndromes were reported, but interesting, all of these symptoms resolved in patients with topical corticosteroids as well as cycloplegics. Unfortunately, long-term follow-up was unavailable for the majority of these patients. As Dr. Varkey has nicely outlined, following a 40-day hospitalization of acute critical illness, Ian followed up with Jay and had back and joint pain as well as tendinitis, or more specifically enthesitis. He also had word-finding difficulties which were improving. From an ophthalmic perspective, his symptoms were quite protean. He had blurred vision as well as mild photophobia, and also an increased need for reading glasses with an increase in his accommodative demand and requiring +1 readers, which he did not need prior to his hospitalization. So Jay referred Dr. Crozier to our service in November 2014. His initial visual acuities were 2015 in both eyes. His intraocular pressures were physiologic. Interestingly, on slit lamp examination, he had mild arcus senilis, which was a bit atypical for a gentleman in his 40s. We attributed that to his severe lipemia that he developed during his period of critical illness. Of note, his anterior chambers and his anterior vitreous were both quiet in both eyes. On fundoscopic evaluation, Dr. Crozier actually had hyperpigmented scars within his retinal periphery with hypopigmented halos, which you can see over here, both in the right and the left eyes. He had one of these actually scars which was associated with a small intraretinal hemorrhage. Focusing in on your top left-hand side, you can see this characteristic hyperpigmented scar with a hypopigmented halo. Looking at the posterior pole, he had a retinal opacity, and with fluorescein angiography, you can see that there's hyperfluorescence of a number of these lesions, which is more easily seen on fluorescein angiogram versus fundus photography. These lesions were seen both temporal and nasal to the optic nerve. A closer look at the anatomy with spectral domain optical coherence tomography showed that there was actually full thickness retinal architectural abnormalities, just nasal to the optic nerve. With the registration slide, you can see in the middle right-hand side of your screen. And looking down more inferiorly, there are several areas of inner and outer retinal architectural change in that affected right eye. So at that point, his findings were most consistent with the posterior uveitis, or more specifically, a chororetinitis, which we deemed to be inactive at the time. We felt that these were potentially post-inflammatory viral changes, and we questioned whether these were similar findings to West Nile chororetinitis. It is notable that he has status post-Ebola virus disease and was considered convalescent. Specifically, his blood PCR for Ebola virus had actually cleared at this time. At this point, we recommended expectant management or observation and recommended a follow-up in about 3 or 4 weeks subsequent to this evaluation. He returned on December 11th, 2014, and was actually at a grocery store when he developed acute onset of symptoms. He developed headaches with a retroorbital aching sensation with severe symptoms, blurred vision and halos, as well as light sensitivity. He promptly called me, and when he called me on the cell phone, he actually told me that he thought he had an episode of acute angle closure glaucoma. And knowing that he's an astute clinician, I knew automatically that's probably what he had. I quickly came down to earth and recognized that I was a uveitis and retina specialist and not a glaucoma specialist. And so the next logical decision was calling our senior resident, Dr. Shantha, for help, which we did and evaluated Dr. Crozier that evening. Visual acuity on presentation at 11 o'clock that night was 20/20 in the left eye, decreased from his baseline of 2015. And his intraocular pressure was severely elevated at 44 millimeters of mercury. Slit lamp examination showed trace anterior chamber cell and mild corneal edema. Gonioscopic evaluation showed no evidence of angle closure, however, and it was unclear with regards to the specific disease process. At this time, we treated him with a combination of ocular and systemic medications to decrease intraocular pressure, including Diamox, as well as a number of ocular hypotensive medications, bringing his pressure down to a more physiologic level. We discharged him with prednisolone acetate 4 times daily, as well as medications to decrease his intraocular pressure. During the ensuing days, his diagnosis actually became a bit more clear, at least in terms of the clinical phenotype. This is a slit lamp evaluation, and taking a closer look at the inferior cornea, specifically looking at Arlt's triangle, with a higher magnification view, you can see clearly that there's a number of non-granulomatous keratic precipitates caked on the corneal endothelium, indicating that this process was not a primary glaucomatous process, but rather that this process was actually that of a hypertensive anterior uveitis with a distinct differential diagnosis. He had escalating pain symptoms over the ensuing 2 days on Saturday and Sunday with increasing anterior chamber inflammation, and the differential diagnosis at that time included a number of viral entities, primarily from the herpes family of viruses, including HSV1, HSV2, cytomegalovirus, as well as varicella zoster virus. We also entertained some of the usual suspects for uveitis, including toxoplasmosis, syphilis, sarcoidosis, and HLA-B27 associated disease, which we thought were potentially less likely at this point. Based on the case series that had been reported, we also considered the possibility that this could represent Ebola virus associated uveitis during convalescence. So our workup at that time, in discussion with the infectious disease service, including a conjunctiva and tear film specimen, looking for Ebola virus PCR. We also discussed at length the possibility of performing an anterior chamber paracentesis for PCR testing, as well as routine serologic testing for autoimmune and infectious entities. How do we perform the AC paracentesis? On Sunday, December 14th, using sterile technique as well as personal protective equipment vetted by the Infectious Disease Service and the SCDU, we were able to aspirate 170 microliters of clear aqueous fluid and obtain a tear film specimen also 24 hours post-procedure. And so what did we find? We actually found that the Ebola virus Rt-Pcr was indeed positive within the aqueous fluid. I'll direct your attention to the y-axis, the Rt-Pcr cycling threshold, and you can see that the value is actually inversely correlated with the concentration of virus genome within the target tissue. On the x-axis, we have the days of illness, 0 to 100, and you can see with the blue dot that this was the cycling threshold, which is 18.7, signifying extremely high concentration of Ebola virus RNA within the aqueous fluid. At this time, the Ebola virus RNA in the blood was actually negative. What is notable that Dr. Varkey has alluded to is that Dr. Crozier had an extremely high level of viral concentration when he was at his peak viremia, and the level of the virus concentration within the eye actually exceeded the viral concentration in his blood at the time of his peak viremia during his period of critical illness during hospitalization. Fortunately, the conjunctival swab and tear film specimens taken pre and 24 hours post-procedure were Ebola virus PCR negative. So how is he doing clinically? Over the ensuing 2 days, he developed worsening vision and eye pain with a decline in the visual acuity at 20/60 in the left eye. You can see that on slit lamp photograph, he has 3+ episcleral and scleral injection, intense eye pain, also diffuse keratic precipitates greater than what I had shown previously. His anterior chamber showed 2 to 3+ inflammatory debris and cell, interspersed with red blood cells and pigment, indicative of a vigorous inflammatory and infectious response. His plan at this time, given his symptoms and given our options, was to start oral prednisone in hopes that the eye would eventually clear the virus. We started at a dose of 1 milligram per kilogram per day, and also escalated our topical corticosteroid dosing to every 2-hour dosing for the affected left eye. The next day, he presented with a hypopyon, about a 0.5 millimeter hypopyon you can see in the inferior corneal angle. His visual acuity had declined to the 2150 level, but fortunately his intraocular pressure remained physiologic at this time. We also escalated his topical corticosteroid dosing at that point. In addition, he also developed vitritis, severe vitritis starting to obscure his optic nerve as well as the retinal blood vessels. Visual acuity remained poor at 2150. We maintained medications at this time, given that his symptoms did appear to be mildly improving, at least in terms of the intense pain that he had developed. Let's fast forward a few days. December 22nd, his eye pain was improving. However, his visual acuity continued to decline. His intraocular pressure plummeted to 1 millimeter mercury in the left eye. And you can see that on the slit lamp photograph on the right eye, he has developed corneal edema with endothelial folds and a central corneal thickness of over 800 microns, normal central corneal thickness being in the 500s. His anterior chamber inflammation had slightly improved, but unfortunately his vitreous haze was significant such that we needed to perform a B-scan ultrasound. And as you can see at this point, he had developed significant choroidal thickening, he had developed peripheral choroidals, and what was especially concerning, his globe was starting to become misshapen, which was concerning to all of us. At that point, to augment the local therapy, we changed his therapy from topical prednisolone acetate to difluprednate in hopes of supporting the low intraocular pressure. Just to summarize his course at this point, his presenting visual acuity was 20/20 with an intraocular pressure of 44 millimeters of mercury, again down from his baseline. In the days leading up to December 24th, his visual acuity remained quite poor, ranging from 2400 to 2800, with recalcitrant hypotony, which was concerning for all of us. So in summary, at this point, this is a 44-year-old physician, Ebola virus disease survivor. We know now that his Ebola virus Rt-Pcr was positive in his aqueous fluid fully 100 days after diagnosis, 2 months after his blood was negative. And his clinical phenotype was that of an aggressive acute hypertensive anterior uveitis, progressing to a severe pan-uveitis with recalcitrant hypotony. Despite our measures, he was developing clinical worsening despite topical corticosteroids as well as systemic medications. And our enthusiasm related to the discovery of Ebola virus in ocular fluid was certainly tempered by tremendous uncertainty related to his management and his prognosis. It was unclear with regards to the role of corticosteroid and the role of any potential antiviral therapy in this disease course. And I'm just going to pause at this point to have Dr. Shantha talk to us about uncertainty and some of the decision making, and I'll have Dr. Crozier talk about his ophthalmic course.
I would first like to thank the ARVO Executive Committee for giving us the opportunity to present today. As Dr. Ye referred to in his case presentation, uncertainty was the underlying theme in this patient's clinical course and is a fundamental component of medical practice. Physicians view uncertainty as a source of threat and anxiety, and it challenges our tendency to be risk adverse. It develops from both patient and physician factors, and tolerance to uncertainty changes as one has more increased clinical experience. There are many different elements of uncertainty in a patient encounter. It first begins with a patient history, which at times can be inconsistent and vague. The slit lamp and dilated fundoscopic examination are subject to examiner variability. Test interpretation, making the correct diagnosis, and formulating an appropriate treatment plan are not always straightforward and are subject to variability. Uncertainty can be categorized into different components. There's technical uncertainty, which is insufficient scientific evidence or data, which is something we struggle with mostly throughout this patient's clinical course. Personal uncertainty is failure of a physician to adequately recognize patient goals. Fortunately for us, Dr. Crozier was a vital member of our care team and decision-making process, and this is not an area of uncertainty we had to overcome. There are multiple points of doubt throughout this patient's clinical course. Initially, the diagnosis was unclear when the patient presented with symptoms of angle closure. We questioned the etiology when the patient did not respond to topical treatment. After the anterior chamber paracentesis, we discovered the causative agent, and we were very hesitant to proceed with more aggressive corticosteroid treatment. As time went on, the vision continued to decline and the uveitis worsened, which often gave us question to our previous management decisions and made us want to consider other alternatives to treatment of this disease process. There are many implications of finding Ebola virus in the anterior chamber. While this did give us a definitive diagnosis, we were left with treatment uncertainty. There is a lack of an antiviral agent with known efficacy against the Ebola virus. In addition, there is concern related to the corticosteroid effect on live active virus. There are scientific implications of finding Ebola virus in the ocular fluid with viral persistence despite clearance in the blood. There's also a small exposure risk to the people involved with this procedure. While a small amount of ocular fluid was obtained from the eye, there is still individual risk to the healthcare providers who performed the procedure, as well as the laboratory personnel who ran the PCR analysis. Both myself, Dr. Ye, and Dr. Varkey all underwent 21-day temperature monitoring after this procedure. The biggest area of uncertainty that our team dealt with was with management. There is really an unknown natural history of Ebola virus-associated uveitis. The pathogenesis is still unclear. Was the uveitis secondary to a direct viral lytic effect or an immunologic reaction to Ebola? Despite escalation of systemic and topical corticosteroids, this patient's anterior uveitis escalated to a panuveitis with a significant drop in his vision and development of hypotony. So how do we deal with this uncertainty? First, we take a deep breath. We had a multidisciplinary team made up of ophthalmology, infectious disease, and Dr. Ian Crozier himself, who helped make management decisions. We reached out to providers in West Africa, as well as talking to the experts such as Justine Smith and Dr. Dan Martin, who reminded us all that uveitis is a team sport. And at the end of the day, we had to balance our degree of uncertainty with making sure that we provide adequate care for our patient and comfort. Thank you.
Thank you, Jessica. That's quite an introduction. After months of staying off the radar, this is the first time I've actually heard my clinicians discuss my case, and it's a very interesting space. It's a great pleasure to be here with you this afternoon. I must say, given my last given my last 6 months, it's a great pleasure to be anywhere this afternoon. You can see by my updated title, no disclosures, that I've begun to talk about the last 6 or 8 months as a dual citizenship of sorts. I was born in Zimbabwe, immigrated to the States when I was 10. I'm a naturalized US citizen, but I don't mean a political citizenship. I mean that one that holds in tension these dual and bilingual roles as both Ebola doctor and Ebola patient. In the past months, I've focused really on the first 2 chapters of this story. It's clearly become an ongoing story, and this afternoon is the first time that I or our team have spoken freely about the sequelae that you've just heard about in any granular detail. I must say it's a particular pleasure to be in a room full of ocular scientists. I've been swimming around in your work for the past 6 months. I've had a mini fellowship of sorts, and it's a really poignant space. Thank you for the organizers for the chance to speak to this particular group. It's also a real pleasure to share that space with these 4 clinicians whom I first met as caretakers and who have since become colleagues and friends, although thank you, Steve, for pointing out my first missed ophthalmic diagnosis. In the next 30 minutes, I'd like to finish this story for you. I want to say it's going to get worse before it gets better. You know, they don't tell you before you get Ebola that it's actually going to become a lovely scapegoat or an excuse to blame many things that are probably part of my germline DNA for years, but now I can blame them on Ebola. For example, I have a tendency to ramble and lose my place. Blame it on Ebola. But I want to make sure that as I unpack just a small part of this unique perspective, that we don't get lost and nor get distracted. There are a few elephants that I hope we can track down together here. Tim has provided a context, and my story fits into this context. We've very recently passed the 26,000 case mark. Yesterday, we passed an underestimate 11,000 death mark in the biggest hemorrhagic fever outbreak in the history of this planet. It's easy to get lost in these intimidating statistics. I hope this afternoon, in my story and a few others, to put some flesh and bone on them. Now, We're focused on the sequel this afternoon, but I first met Steve in November, I suppose, of last year. That story began, as Jay has related, really in September when I met Jay and Tim Uyeki a bit later in the hospital. But for me, and it's very important for me to begin with this, I'd like to unpack a little bit of that dual perspective as an Ebola doctor, and that's necessary to step into Chapter 1. Chapter 1 began in August, and it began in Sierra Leone. Notice, this is a graph of the weekly case incidence in Sierra Leone. Please notice that the peak in October and November and December has changed dramatically. That's in large part because of a delayed but massive international response that puts us in, hopefully, this last mile. Notice something else. In the months of October and November and December, there were more cases in a 5 to 6 week span in this single country than there had been in all countries in all prior epidemics in the history of this planet. The scope was remarkable. I'd like to point out something else. A couple of months ago, at the peak of this response, there were 24 open ETUs. That's an Ebola treatment unit in Sierra Leone. That is Disneyland for me. When I first went in August, there were 2. And for a time, when the MSF unit shut down, we were the only admitting unit for the country of Sierra Leone. 2 months prior to that, there were no Ebola treatment units. So I'd like to turn the clock back a bit. August 2014, it was a very different story in Sierra Leone. The Kenema government hospital, which had a pre-existing Lassa fever infrastructure, became a natural place to begin to care for the first patients as the virus disregarded international borders and took root in Sierra Leone. It wasn't a typical ETU. MSF knows how to do this. They can take an ETU and drop it in the middle of an open field, and it's self-contained. Everything you need is there. That wasn't the case, as this Ebola treatment unit had to evolve week to week in response to an unexpected volume of cases. The World Health Organization stepped in to provide technical assistance to a group of Sierra Leone national staff, but nobody really wanted to own this process. In late June of the year, MSF opened the Kayahoon ETU, but in early August, as the virus crossed the border, it began to flex its muscles, and caseloads soared initially in the east, but quickly the virus turned and began to look towards Freetown and the west. And I joined this small clinical team. This is John Shefflin from Tulane. He had been working on Lassa fever for years. Susan McClellan, also from Tulane, and my old friend and colleague, Shevin Jacob. And our small team provided technical expertise and clinical expertise to care for a number of patients. They don't let you do this for more than 3 or 4 weeks if you're on the wards every day. So within my first week, a new team came in, and I became the lead clinician. This is David Paremka from Cleveland, George Reese and Kate Hurley from Montana. Nahid Bedelia is not shown. And you can see coming out to the veranda a number of convalescing but still PCR positive survivors. Probably the first critical capacity as someone comes into the ETU is determine whether they're a suspect and therefore need to be admitted to the suspect ward and PCR tested. Most patients were triaged according to a WHO algorithm, although new tools are being developed. I want you to notice in the corner of this picture, though, that we also had ambulances coming from all around the country. There were several occasions when I opened ambulances and found that 2 or 3 of the 5 or 6 patients crammed in the back were already dead. I've taken care of infectious and sick patients in Africa for years. Not just in that setting, but also after traumas like the World Cup bombing in Kampala in 2010. Nothing prepared me for the realities of an Ebola treatment unit. I've called this virus often a villain of the first order. Not only does it cause disease with a very high mortality, but it does it at a pace and with an aggression that absolutely robs patients of their dignity. So while we were prepared technically to take care of patients, nothing prepared us for the devastation we were to see in individuals, in families, and in communities. That small team was actually much bigger. In addition to the WHO clinical advisors, there was a group of Sierra Leonean nationals. Most of the doctors had left or died by that time, but there was a group of understandably unsettled and anxious nurses, hygienists, lab techs, many of them who had already seen colleagues, family members, and friends die within the same walls. And you can see us standing here, including with a beaming survivor, very happy to escape with his survivor's certificate. And in that setting, our small team took care of 80 to 90 patients at any one time. We don't show you the inside of the confirmed unit, but in the unit, people were struggling for their lives at every turn. Really two types of people. If you were lucid and clear-headed, you were lonely and terrified. And as was often the case, a vacant encephalitis was settling in and patients were delirious and confused. And in that very grim setting, people died. People survived. You can see here a group of relatively well children who just in the prior week had been fighting for their own lives. The young boy in the red t-shirt is Courage. Inside these walls, fighting for his life, is his younger brother, Success. Odd or apt names, right? There were many nights when Chev and Jacob and I, unable to get intravenous access in these children, sat as the last work of the night to deliver 10 milliliters at a time through syringes of oral rehydration solution, hoping that these children would survive the night. And we would look at each other and wonder about the aptness or the appropriateness of their names, Courage and Success. And in that very dark and grim setting, we began to see remarkable things happen. Almost everyone who enters an Ebola treatment unit has already lost parents or siblings or children. And parents who had lost all their children began to care for children who had lost their siblings and lost their parents. Children who would have starved lived, and in a strange foster care of sorts. And in this very dark place, and it's nothing if not a dark place, these little cracks of joy began to push their way through. One night I met was severely dehydrated, unconscious, lying on a mattress on the floor in pools of his own diarrhea and vomitus. His two younger brothers, who were well at the time, were wide-eyed and terrified, still positive but refusing to leave his side, sitting in the same pools. I didn't expect him to survive the night, but he did. And the next day, and the next day, and when he emerged essentially from the edge of his own abyss, and his brothers subsequently became ill, this young boy became an 11-year-old father and mother to his younger siblings. One of my greatest regrets is that I never got a chance to put my arms around these boys outside of my spacesuit in PPE. This is a picture taken after I had left Kenema of them walking out in fresh clothes, aptly with the older brother around, emerging as Ebola survivors, in large part, I believe, because they had each other. And then these shocking things happened. Please don't get lost in the numbers. In the middle of this, the national staff, nurses, hygienists, lab techs, were daily going into these grim walls and doing it quietly and with very little fanfare. Can I pause for a second and tell you about one of them? This is Nancy Yoko. It's important to me that you hear and remember her name. Nancy Yoko. She was our head nurse. She was a kind person, but she was tough. And she was the glue that kept together a group of understandably anxious national healthcare workers. She became a good friend, and I depended on her immensely as the lead clinician. She was exhausted. And as September turned, she came to us with fever, and we admitted her into our suspect ward, moved her to the confirmed as the PCR came back positive, cared for her as she deteriorated, and then mourned with our whole hospital community as she died. I wasn't long in Kenema. I'm often uncomfortable with the language that people use. But there are a group of national healthcare workers in all three of these countries that have been doing this daily, quietly, resolutely, and with very little fanfare, and been doing it for months. And they demonstrated an uncommon heroism that I will never forget. And other things happened. During my time as lead clinician, I supervised several evacuations. One of the first was a young British nurse who went into the epidemic when everyone was fleeing with just a backpack. He was doing yeoman's work, and he came to me one day with fever and pharyngitis. His diagnosis came back later that night, and I entered his room in full PPE with little need for words. Both of us had seen the natural history of this infection play out many, many times. And this is one of the last ones. You can see this grainy photo of me saying goodbye to the Phoenix airplane and the team that I had seen several times. In fact, I made a wry joke to the team that I really, really didn't want to see them again. And a few days later, I found myself on the same tarmac, with the same jet, and with the same team, this time as a patient. I had my first private jet ride in an isolation bubble, and obviously my first selfie in that setting, but you can see that I wasn't feeling well at the time. In the interest of time, I'm not going to spend any time talking about my acute illness, although I would like to talk about it for days. Jay has covered that so well already, but I would like to show one slide and make one very important point. Let me give you some perspective on this. If you had told me on day one that a week later I would develop respiratory failure, encephalitis, kidney failure, I would have estimated my chances at survival at 0. And there are many clinicians, many with some experience, who might have suggested that providing that level of critical care to me was perhaps futile and perhaps added to risk. And some part of me might have agreed. So I want to make the point that as the Emory clinicians were fighting tooth and nail for me when I couldn't, as they intubated me and mechanically ventilated me, and as they provided support for my 0 GFR, they changed the game and were essentially in that space walking on the moon. Let's get back to the story at hand. I emerged after 40 long days and 40 long nights as an Ebola survivor. And I joined the ranks of this small and semi-exclusive club. So this is one morning in Kenema where we discharged 9 survivors. I hope that you can see the joy on their faces as they come out of their personal hell before the unit, a lonelier hell in the unit, and now have made it away from the abyss. The same joy is on my face behind them as I'm carrying lists of PCR tests that are finally negative. You know, in October last year, the survivors from Kenema were polled and asked, what are you struggling with after EVD? And heading that list was a chronic disabling fatigue, headache, joint pain and myalgia, neurocognitive problems, and surprisingly, 40% of them complained of eye symptoms. And it turns out that I'm not so different from 10 to 15,000 West African survivors. I've developed a chronic disabling fatigue that I often refer to as feeling punch drunk. I've developed an inflammatory sacroiliac arthritis that's combined with an Achilles tendon enthesitis. It's made me swear that my B27 was going to be positive. It is not, but something else is awry, whether it's a molecular mimicry or something to do with the role of cartilage, perhaps as being an immune privileged site. Indeed, the virus did a dance in my brain. I won't show you the MRI, but there's significant evidence of a very severe hemorrhagic encephalitis and the footprints that it's left behind. We're going to focus already on these ocular signs and symptoms, but I've also developed a left-sided hearing loss, which has not been written up, at least before. As I came off steroids recently, a constant tinnitus has roared, which I think will be a bedfellow for life. Peripheral neuropathy, hair loss, although it's growing back, much curlier, by the way, and a terrible insomnia, actually, very irritating insomnia, even as the steroids came off. You know, there are lots of lists of post-EVD symptoms, self-reported symptoms, but there's very little, a paucity of data that looks at it in a controlled fashion. These are the 2 studies. Rowe et al. In 1999, after the DRC Kikwit outbreak, followed 29 survivors and found that arthralgias and myalgias dominated the game, abdominal pain, fatigue, and anorexia. Many of those symptoms were still present at 21 months, and there's some evidence that survivors struggle for years. Published a few weeks ago, this is an experience from the Bundibujo outbreak in 2007, in which they followed almost 50 survivors for 29 months, and they found, interestingly, these things that were different between the groups. Notice that blurred vision, and retroorbital pain were significantly different between the groups and controls. So, let's get back to the story at hand, right? As Steve has told you, perhaps a better title for this chapter 3 might be The Eyes Have It. So let me get back to this. You know, this is not what I considered to be a fun way to spend my Sunday afternoons in December after leaving the unit. And I must admit I was a little bit nervous as Steve was approaching me with his 30-gauge needle from this particular space on this Sunday afternoon. Also, you can see, having lost 30 pounds during my 6 weeks in the hospital, I had a little less hair on my face and a little less hair on my scalp. That 30 pounds since Steve has given me these steroids has come back and more. So let me remind you of the finding. Before that, as I was sitting in this chair, I remember nervously, not because I thought it was going to be Ebola, but nervously because he was coming at me with a needle for my eye. Surely this is not going to be positive for Ebola. Just in case it is, remember this moment and what it feels like to be right in the middle of a paradigm shift. Later that afternoon, or that evening, the rapid PCR came back. Steve has already mentioned the real-time Rt-Pcr results, and the culture was pending. A key question here was, could this be actively replicating virus 14 weeks, 100 days after my disease onset? Surely not. It is important to remind you, and as we talk about this, the conjunctival swab and tear film specimens, even at a PCR that high, were importantly negative. This cannot add to the stigma that West African survivors are already struggling with. And my blood PCR was negative. I hope this stimulates more questions than answers in you. Was this active replicating virus? Is this a novel finding? Has this ever been found, Ebola in the anterior chamber? What was it doing there? How did it get there? How did it avoid systemic immune detection? And as Jessica has raised, what role did viral replication and lytic infection play in the pathogenesis? Tim has already mentioned that we have a hint of persistence in another specific site that we consider immune privileged, but until this recent case in Liberia, it's really been of uncertain gravitas, both in terms of causing clinical pathology or of its role in transmission. That has changed. The reference is down below. This is Zimbabwe. In 1975, I was 5 years old, somewhere around Bulawayo. At the same time, a 20-year-old Australian traveling in Rhodesia, which then became Zimbabwe, became sick with a febrile syndrome. He was taken to Johannesburg, and he died. His girlfriend got sick, and she survived. But a nurse who took care of him got sick, recovered, and her blood was positive for a cousin of Ebola, the Marburg virus. 3 months later, she developed an acute hypertensive uveitis and an anterior chamber tap had a positive aqueous humor Marburg virus culture. This was reported in the British Journal of Ophthalmology in 1977 with this very interesting tag. The Latin is ex Africa semper aliquid novi, which roughly translates, there's always something new coming out of Africa. Interesting that 40 years later, the same is true. There has been a hint. We've classically considered this, as Tim has said, since 1976, a very acute infection. But there has been a hint in some in vitro and cell culture models, if you use defective interfering particles or immune-deficient mice, that we can make Ebola persistent. There's been a recent, more exciting hint that shows that in mouse and bat cell lines, you can create persistence that can be activated by RAS and MAP kinase pathways. We've already mentioned the semen, and now this example in the eye. So, remember this picture? Steve was peering in here, unable to see my retina and my optic nerve through this dense inflammatory debris. From the other side of the obstruction, I was peering out from the same retina and the same optic nerve, unable to see Steve with increasing difficulty. We've mentioned already that after treatment with ocular hypotensives, I presented with hypertensive uveitis. Very quickly it normalized, and then the pressure bottomed out. And so for 9 days, I'd had a pressure of 0 or 1 or possibly 2, with hypotony developing and subsequent complications that he's already mentioned. This occurred on high-dose oral steroids already. So on day 11, this is 4 days later, he's shown you this already, the visual acuity 2800, the intraocular pressure 1, and we feared the loss of architecture as the eye became softer and softer. I hope you notice, your expert eyes, that something else has changed. Isn't the song, Don't It Make My Brown Eyes Blue, right? Don't it make my blue eyes green? I woke up one day and noticed that the color change in my left iris had changed significantly, recalling Fuchs' heterochromic iridocyclitis and the recently, or not so recently, rubella association. At the same time, high-resolution ultrasound biomicroscopy shows that the hypotony is having an effect. And as the ultrasound probe is pushed down on the left, you see collapse of the anterior chamber and significant changes in the iris and the ciliary body across the way. We've already mentioned this difficult, uncertain land in which to make decisions. And I'm so glad there were 3 or 4 or 5 of us sometimes each day spending an hour post an exam thinking about the next routes. But a key question was how much of the pathology was related to inflammation versus direct effects of lytic viral replication. We knew at that point that the aqueous humor, as expected, was Ebola virus positive. I had progressed on high-dose oral steroids. Did we need to escalate anti-inflammatory treatment? That's really mitigated and measured by the concern that we might, like HSV, unleash a more severe retinitis. But we began to wonder whether this ocular pathology might represent an unknown tropism for the epithelial cells of the ciliary body or the pigmented cells of the iris, leading to hypotony and heterochromia. So we began to think of ways we could shift that playing field and look for some experimental therapies. I will tell you, it was a dark December, so I wish this Devil's Cut whiskey had been part of the therapy. However, it wasn't. We were looking specifically for Ebola-specific options that might shift the playing field. I can't talk about this in great detail for time and other reasons, but eventually we settled on T705, the favipiravir drug that has an effect against a number of other viruses, including influenza. The FDA and the company allowed us to get emergency indication. And on Christmas Eve, I was admitted to the same bed from which I was discharged in October. Steve Ye sent his family away and spent Christmas with me, and I spent it with Jessica and Steve and my youngest brother, the whole time mimicking the Dread Pirate John Roberts. 5 days later, Steve felt comfortable about escalating anti-inflammatory with the antiviral on board, though we didn't know much about penetration. I was, of course, concerned about my right eye as well, which had those posterior lesions. So this is my admit to Emory. On the day of admission on Christmas Eve, I started T705. 5 days later, I had a steroid injection. Despite that, it continued to be. This is now within 3 weeks, I went from 2015 to hand motions only. And by the end of the year, given a blow to my morale that the last 3 weeks had been, the team decided to send me home for Christmas. Right before I went home, we interestingly caught this slice of an ocular ultrasound, recalling the yin and yang that I just spoke about as my vitreous detached from the retina. You can see optic nerve edema, vitreal detachment. But as I went home, patched on the left, unable to hear on my left, with children loving to look at me and adults taking their eyes away, I thought I had lost the eye completely. 4 days into the new year, I'm not going to talk about the details, but I developed a bizarre febrile syndrome. And in the context of that febrile syndrome, I was admitted to the ICU in Phoenix and then transferred back to Emory. I began to wonder whether my vision was improving. You can see from this graph that just before I went home for Christmas, there was a little bump in the intraocular pressure. And indeed, please stay tuned for the details of this. It will be coming out soon. But there was a remarkable increase in my visual acuity. As the vitreous detached, I realized that I was able to move around this obstruction with my extraocular muscles and find a wormhole or a portal through which I could see quite clearly. Initially at 20/60, then 20/50, and those details will come down the road. I'm not quite back to baseline, but I'm pretty close. So there was a Lazarine return of the eye in the first or second week of January. I hope this provokes more questions than answers. Severe, sight-threatening pan-uveitis is a complication in the convalescent phase of EVD. In that setting, the virus can be detected by PCR or culture at high levels in the anterior chamber of the eye, months after clearing the blood. Our hypothesis is that the eye and the blood-retinal barrier likely breached that barrier during the acute infection at peak viremia and in the setting of ocular immune privilege, which I would love to talk to some of you about. Viral replication was ongoing at low levels, undetected, without setting off any alarm bells, as the virus essentially stopped paying rent but squatted in my posterior eye. At some point, it reached a tipping point in which I developed this hypertensive anterior uveitis. Was that a characteristic of the virus? Obviously, sequencing and comparing the blood and the eye is very important. There are some differences, but clinically or in the lab, phenotyping those differences will take some time. Was there a stress activation with MAP kinase or other molecular activation pathways, or some other unknown collapse of immune privilege related to this issue? You should have questions about pathogenesis. What was the role of virus versus the role of inflammation versus some combination of the two? What's the natural history in terms of my treatment without a corticosteroid, without an antiviral? Sleuthing out this question, I hope, is very relevant to this room in particular. It will require some animal modeling, and I hope potentially down the road some clinical trials. But a key question that I hope is in your mind is, what's the incidence, what's the burden of disease, what's the natural history of this process in West Africa? Am I an outlier, or is this persistent virus in a sanctuary site, or this sanctuary site, more common and undiagnosed? I'm going to skip through this, except just to say that I think there will be a spectrum, a heterogeneous spectrum of disease. In some patients, it will be site-threatening. We know that already. The window in which to intervene in the natural history, if we can, is short, probably within the first 3 to 6 months after leaving a unit. That is going to require attention to mid-level providers who can triage, to expert providers who can run slit lamps and diagnose uveitis, and making sure that we can provide at least standard treatment, topical drops and oral steroids in selected patients. What's the true incidence of ocular disease? What's the true incidence of viral persistence? You know, there's interesting animals who have been given interventions for research studies and, in a sense, have a delayed death phenotype. So they die a bit later than the control animals. In these animals, they seem to have an altered tissue tropism. One of those tissues is the eye, and you can see in one of these macaques that there's immunostaining for Ebola antigen throughout all layers of the cornea. So perhaps I'm just an outlier given the fact that I had such severe acute disease. And I hope you're thinking, these boys, that's courage and success, and that's Victor, Sheku, and Ibrahim, all emerged from the unit. I hope you're thinking about the ramifications for this for West African eyes. John Fankhauser, who took care of patient number 1 and patient number 2 in Monrovia, recently invited us. And 2 weeks ago, Steve Ye, Jessica Shantha, and Brent Hayek from the Emory eye team spent a week looking at over 100 Ebola survivors with eye complaints. During that week, in addition to taking histories and checking visual acuity, we built mid-level physician, mid-level provider staff capacity in those regards. We took a moderate amount of stuff with slit lamps and indirect ophthalmoscopes and built physician and expert staff capacity as we left that stuff behind. The goal, and this is important, was driven by the need to provide timely and appropriate patient care, but at the same time to build capacity quickly in multiple levels of providers, and finally to quickly learn about a disease so that we can refine and inform diagnostic and treatment protocols. Can I give you just a quick biopsy as I end here? Just got 1 minute left of what we saw. This is a 29-year-old female who was in the Ebola treatment unit in November and presented with decreased visual acuity and eye pain for 3 or 4 months. On examination, she had finger counting only in the left eye, and the exam showed diffuse chorotic precipitates, posterior synechia, and a cataract. And she had probably downstream sequelae of the same process that I had, a severe left panuveitis. She was treated with drops and oral prednisone, and in fact, in the course of a week, actually had the early signs of some improvement. Interestingly, this is a 42-year-old who developed pain and tearing and a blurred vision in his right eye while in the ETU. In the interval, there was no improvement. He had finger counting only at 1 foot in the same eye. There was a visual field deficit, and you can see lesions that recalled toxoplasmosis, or perhaps what you saw in my eye at the beginning of this presentation. But the history and timing suggests a posterior uveitis in the acute infection related to Ebola. This last case, a 12-year-old who was in the unit in September of 2014, presented to us with decreased vision over the last 3 months and white glowing in the eye. And you can see on examination posterior synechii and a very dense white cataract that has evolved in the last few months in a 12-year-old. This is obviously relevant for this child's sight, but another important issue. Probably no one's going to be doing vitrectomies or putting needles in eyes given this finding, but there are a number of mid-level providers in West Africa who take out cataracts. When is it going to be safe to do that? That's up to this point unknown. So I've made the point as I finish that there are elements of my acute infection that were really important and were truly global health, as long as the northern expertise can translate quickly into the south. The eye disease, there's a great need to prevent what is, in essence, a second death in these Ebola survivors. So we are working currently on developing these diagnostic and treatment protocols driven here by Steve, and also in understanding other complications. Please don't get lost in these numbers. Here's a poignant picture of Nancy Yoko with 2 survivors whom she cared for. Those survivors and me can still tell these stories, but Nancy can't. So I'm really thankful for your attention as we hear, and I'm able to tell her stories because she can no longer tell them. I really appreciate your time. And my acknowledgments are far too many to list. Can I first say I'm a grateful patient for the care provided me in my acute infection. And I'm a grateful patient for this I-team. 2015 has been realized. It's not over till it's over. We've had some hints from what Tim has said that Liberia may be declared Ebola-free in a few days. But remember, it takes 6 weeks till the last case and the last contact for it to be declared Ebola-free. So 1 case is too many. We cannot put out 99% of a fire. There are some long-term lessons here that I'd love to talk about outside of this setting as I finish. Thank you so much for your attention.
A truly amazing story, as we've heard. We certainly want to thank the Emory team, the CDC, and of course, Dr. Crozier. I think just to show what kind of a person he is, when we had lunch and asked, what's the next step? It's going back to Africa and continuing his work, so congratulations. This will conclude our symposium as well as ARVO 2015. Wishing everyone a very safe trip home, a full year of discovery. Keep the science going strong. We'll see you in Seattle 2016. Our team will be here for a period of time to answer any questions. If you have some questions, please come on up front, please. And thanks once again, everyone.